Thank you. Hi, everybody. Big thank you to all of you for joining us tonight. We've got a great turnout this evening. And I'm really excited about the information that Andrew's put together to share with you tonight, all about recovering from an Achilles injury for athletes and active individuals. And I can honestly say from the people's names that I recognize on this call, all of you are athletes and active individuals, so it's really great to have you here. A little bit of logistics this evening before we get started, and I introduce the star of the show. Again, my name's Robin Hansberger. I am Business Development and Operations Manager at Hansberger Physio Plus, and I've got Andrew here with me this evening, one of our resident physiotherapists. Tonight is going to be really interactive. Andrew's got some really great information to share with you guys. And we really want you guys to be able to ask as many questions as you like. So please feel free to use the chat function down on the bottom or on the side of your window. Or if you're comfortable, you can unmute yourself and ask that question as well. There's no silly questions. This is purely an educational webinar, and we really hope you take away some key pieces of information that will help you with your injury, but most importantly, preventing that injury. So before I hand things over to Andrew, I just really wanted to introduce him properly. So Andrew is one of our newest physiotherapists on the team. He's super driven, joyful, and adaptive. He's got such a caring personality, and that's one thing that I really love so much about what Andrew brings to the practice. He graduated from a Bachelor of Science in Kinesiology from the University of Waterloo, and then is a Master of Science in Physical Therapy from the University of Toronto. Andrew has a strong interest in orthopedics, exercises, and exercise prescription, but most importantly, manual therapy. And you're going to hear a little bit about all three of those topics tonight. Andrew's super passionate about sports medicine, high performance, field care, and does a lot of really exciting volunteer opportunities on the weekends with different Skate Canada events, ultimate frisbee events, and that kinds of things. He's really excited for opportunities to use his manual treatment skills and teach exercising techniques. Andrew is an athlete at heart, played ultimate frisbee at the varsity and club level, works with a few of the different ultimate frisbee teams in Toronto. Then in his free time as well, he enjoys playing football, volleyball, tennis, and then he's a Netflix guy and loves finding new shows to binge as well. So I hope I didn't butcher that too much, Andrew, but I'm going to pass things over to you tonight so we can get started on some of the great information you put together. Take it away, okay?
Thanks, Robin. Wow, yeah, that was a really good introduction. I'm almost flattered. It is.
I really practiced that one for you, you know?
Yeah, so yeah, Robin really explained really well about kind of my experience, my background, both as a physiotherapist, as an athlete, as someone who's encountered Achilles injuries before. And one thing that Robin didn't mention is that the reason why I really thought this was a really interesting thing and something that I wanted to talk about is that I've actually suffered from these similar injuries to Achilles pain before. So I've been on both ends, both as a therapist and as the client. So again, there's a lot of information that I want to share from both sides, and I really wanted to just spread the knowledge, just hope that everyone can take something away from the presentation and be able to learn something.
Awesome.
So let's get started. Just talking a little bit about what we're going to go over. So I'm going to go over quite a few different topics. So starting with a little bit of background on the anatomy, just to give everyone a basic understanding, kind of the same fundamental level of what the structures we're going to talk about, the sources of these injuries and kind of where they come from, how they relate to different sports and different activities that you guys may or may not be aware of. Talk a little bit about the current research that's going on and a lot of the current research that's being done, how this is relevant to you, how this relates to other different kinds of rehab and how different methods of rehab work either in conjunction or one works better than the other. And again, probably most importantly is how it works for you and how it specifically can help you. So before we get into what I want to talk about, I want to hear a little from our audience. So I want to know what your experience with Achilles injuries or pain is, whether you're currently dealing with Achilles injuries, whether you've dealt with Achilles injuries in the past, or if you haven't dealt with it personally and you're just here to learn something or just here to get some fun information. So you can feel free to use the chat and just kind of.
Yeah, let us know. Drop that in the chat. If you've had an injury, write yes. If you haven't, write no. Or if you're just interested in learning, you can just drop a learning bomb in there.
So I'll just give a quick minute on this slide just so everyone can put in their information, and then we'll move on.
One yes here. So I think there already is someone who's really going to benefit from this. Chronic pain in the Achilles for years. Really sorry to hear that, Denise, but you're in the right place. Andrew's got a wealth of knowledge. So I'm really excited to hear what he has in store for us.
Give it another 30 seconds and then we'll move on.
That's okay if we're shy as well. No worries.
Yeah, no pressure to speak up, just giving everyone the time to type. I know some people want to take the time to explain.
Awesome. I think, yeah, we've got actually some great information. Had a torn Achilles, treated with stem cell injection, which fixed the tear, but still experiencing some stiffness. So that's a pretty intense one. And there's also another gentleman who has had a lot of on and off Achilles tightness. So really just wants to learn more about how to deal with that. So I think we have a really great group here, and there's going to be a lot of great knowledge transfer.
Yeah, I think this is a really good range of experiences, both personally and just wanting to learn. So this is great. I hope everyone can take at least a little bit of some new knowledge or new information that they can use for themselves. All right, so let's get started. So let's start with talking about the anatomy of the Achilles. So this very general information. So the Achilles tendon is that long band of tissue that attaches your calf muscles to your heel. So you can see it kind of in the diagram here with your calf muscle on top. It's really important for a ton of movements, whether it's walking, running, jumping, really anything that involves propulsion and locomotion. And additionally, it has that elastic property that helps it absorb contact, so absorbing the forces through the foot. If you think about it, really your entire body weight is constantly being held up by just your two Achilles. So your foot is taking all the load of your body just through that single tendon. So it's not surprising that the Achilles tendon is the largest and strongest tendon in the body. It needs to be able to sustain that weight on and on consistently throughout the day, whether it's just standing or even if you're running, sprinting, jogging, jumping, whatever it is.
Wow, when you put it that way, that's a pretty interesting fact. I didn't really put that together, but that makes a lot of sense.
Yeah, a lot of people don't think about it, but really imagine yourself walking and really your Achilles tendon is taking all of that tension throughout your entire body just through that tiny little band in the back of your heel. So there's a ton of pressure being put through that. And again, that's why injuries are so important to rehab, and understanding how this tendon works really helps with the recovery. Which brings me to the last point, which is actually the key point for recovery, is that the tendon, a lot like other tendons and other ligaments, it doesn't actually have a great blood supply. If you think of what blood supply does, it provides nutrients, provides oxygen. So a lot of it goes towards muscles, the ones that need all that energy and needs to keep functioning and working hard. Tendons don't really receive that blood supply. It doesn't really need it. It's just kind of an elastic connective tissue. But when it gets injured, that's when it becomes important, because the blood supply is what helps with recovery, helps that tissue heal. If a tissue doesn't have as good blood supply, it's not going to be able to heal as quickly as versus a muscle or something that does get that good blood supply. So like muscles, skin, other tissues. We're going to talk about why this is important when we address the specific injuries that we'll see. So specifically, what's Achilles tendinopathy? Tendinopathy is the condition that I'm going to try to address the most. It's a very large, over-encompassing term, and it's got a lot of different definitions. But for the purpose of this webinar and for this presentation, I'm just going to use a very broad definition, which is the accumulation of microtrauma leading to disruption in the structure of that tendon. Now, what does that mean? That means repeated small traumas that may not be significant in on itself, but when they build up and when they accumulate, creates small tissue alignments, small breakdowns in the tissue that need to be healed. And that healing process creates inflammation. Normally, this inflammation will come and go and it'll be no problem. But when you repeatedly stress the Achilles tendon, what happens is that inflammation will stay. And that inflammation staying is what creates the tendinopathy and creates that inflammatory pain. The common mechanism for this overuse and this repeated microtrauma is overusing and chronic stress on that tendon. So you think of people who are constantly walking, constantly running, putting stress on that tendon without it giving it adequate time to rest. Other factors that I'll go into in the next slide are circulation, lack of flexibility, your gender plays a factor, how your hormones and metabolic factors as well. But for the purposes of rehab and recovery, I really want to focus on that overuse. That's kind of the most important aspect of tendinopathy that a lot of affects most people in kind of the most general terms. with overuse, we can see it both in athletes. So if you think of marathon runners that are constantly running, constantly putting load through the ankle, sprinters, jumpers, those are the main exercises we think of. But even in non-athletes, people who have very physical jobs that are always on their feet or just constantly standing and moving around, those also count as repeated microtrauma. And it could lead to eventually having disruptions in that tendon structure and creating tendinopathy and leading to pain. Tendinopathy in itself is not a large injury. It's considered a minor or lesser injury. It creates pain and it's really annoying to deal with because of all that nagging pain and injury. But the reason why it's so important is because it's used as an indicator of further risk. A lot of times you'll see people with tendinopathy with kind of lower levels of pain, but a lot of stiffness and tightness. That's a sign that if they continue on their activity, whether it's work or sport, they may be at risk of injuring that tendon more or even the surrounding structures. So the other risk factors, some of them are ones that we can't control, such as age and gender. So obviously with age, as you get older, the tendon structure becomes less solid and it has higher susceptibility to injury. For gender, it is seen in more recent studies that it does happen more in males than females, but that's kind of independent to sport. A lot of different activities were looked at and they did predominantly look more at males. So it could be a little bit more of a balance there. Bone spurs, also something you can't really control. Sometimes people are more susceptible than others to developing bone spurs, and it creates more tension and stress into the tendon. Now, the other factors are ones that we have a little more control over, and some that as a physiotherapist, we do try to focus and look into a little bit more. Firstly, so increasing the amount of activity or sport you do, whether it's starting a new sport or getting back into a sport after a long break, that increase in intensity, that increase back into activity provides an additional stress, an additional stressor to the tendon that may aggravate and may create the symptoms of tendinopathy. Having tight muscles. This is the key one that I'm sure anyone who's gone to physiotherapy has heard before. Like, your muscles are tight, your muscles are tight. This is going to create a problem. I'll talk a little bit more about why this creates a problem, but this is a main thing that physiotherapists want to look at, because tight calves and tight calf muscles is a really strong indicator of Achilles tendinopathy, because the muscle attaches to the bone with that tendon and it goes through a lot of stress when it's tighter. The last three are kind of connected. They're all kind of within the same overall purpose, which is if you have improper footwear, or you're standing on an uneven surface, or your feet are overpronated, like the image on the right, you're putting a lot of excess stress on this tendon because it's not in proper alignment. So if you take a look at the picture on the right, you can see that gentleman's ankles, it's turned outwards. So you see, if you draw a straight line through the calf and into the heel, that the Achilles is almost at an angle. That angle provides an additional stress to the Achilles, so that when you're doing normal movements that might not otherwise be considered extra stress, you're applying more stress onto the tendon than you normally would. And this will increase your risk of tendinopathy or further Achilles pain. Before I talk a little bit more about the research, there is something I want to bring up that's more on the clinical side, more on the scientific side. But I feel like it has a really great image that I'm going to show later that helps you understand the progression of Achilles tendinopathy and how it goes from a lesser injury to a more serious or more chronic issue. The model that I want to use, it's one of many models used to depict tendinopathies, is the tendon continuum. Now, the tendon continuum proposes that there's 3 stages to tendon injury, starting with reactive tendinopathy, which is just a light inflammation, which grows to tendon disrepair, and eventually degenerative tendinopathy, which is that permanent structural damage that we want to try to avoid. In the most basic sense, the continuums dictates that if you increase the load, that you would be moving to the next stage of the injury, and decreasing the load, you would go back to a previous stage. We're going back to decrease that risk of injury. Now, I'm sure since many of you have had Achilles pain or are still dealing with Achilles pain, you know it's not that simple. It's not just about increasing or decreasing load. So that's the complexity that the tendon continuum, using that image, they try to depict a little bit more. And I'll show you that image right now. So there's a lot going on in this image. There's a lot of arrows, a lot of words going on. So we'll start in the beginning. We'll start at the normal tendon. Normal tendon is, if you think of a perfectly healthy tendon, nothing going on, perfect, getting adequate loads, not overstressing. That's where we want to be. Now, if we follow the red arrow down, As we increase the load to the tendon, we're gradually going down through the stages of tendinopathy. So starting with reactive, then disrepair, and at the very bottom, degenerative. If you follow the green arrows, we're going to go back up to modify the load to more adequate loads and slowly move back towards the normal tendon. That's the most basic sense. Now, of course, you notice there's more arrows going on and more things. And that's the important part of the research that we're currently doing towards tendinopathy, which is that when you take a normal tendon and you decrease the load even beyond the point of an adequate load, you're actually shielding it from stress, which is not a good thing. Because when you shield the tendon from stress, you're actually making it easier to move into reactive tendinopathy with a normal amount of load. So even a load that you would have been able to tolerate before would now lead you into creating tendinopathy. So that would be an example of inactivity. If you go from someone who's constantly walking to being pretty active to someone who's sedentary, like probably a majority of us during COVID who just sat down and wasn't as active, we start to shield our tendons from stress, actually make it more susceptible to injury. Now, of course, if we optimize the load and we continuously apply this load in an optimized format, we create the area on the right, which is adaptation. Adaptation is the goal of both physiotherapists and for researchers. We want to figure out how to create an adaptive tendon that's able to slowly get stronger and be able to take a greater amount of load without moving down the stages into tendinopathy. So that's what the research is going to start. The research that I'm going to talk about later on, we'll move a little bit into.
Now, I have a question for you, Andrew. If I were to have an injury, let's say I just tore my ACL and I've been fairly active before, are people who have those types of injuries that make them more sedentary, more at risk for tendinopathy as they begin to recover?
So the short answer is yes. So by having that injury to your Achilles and having that injury that you're recovering from, that's already putting you in a stress shielding because after an injury, your body naturally wants to shield your body from stress. So you're already putting into stress shielding because you're no longer a normal tendon. You've been injured. So by being in this position, we want to make sure that we gradually increase the load. So we move from stress shielding into normal tendon instead of into reactive tendinopathy. Now, of course, if you're an athlete and if you've been very active before, that's a separate factor, and that might actually improve your chances of getting back to normal recovery because your normal tendon strength was probably better than someone who wasn't as active and wasn't as diligent with their exercises. So again, there's a bit of balancing, and a lot of it is why when I get to the research later, it's going to sound very paradoxical, very contrary, because it seems like, you want to be adding load, but you don't want to be adding load, but you want to add enough load, but you don't want to move it. It's going to sound very confusing. And that's why a lot of times we're constantly researching and constantly looking for different ways to optimize recovery and optimize rehab for Achilles tendinopathy.
So we have one more question from the group. Thank you. That's a great answer. It helps me understand a lot. Is cycling a good or bad activity regarding the impact on the Achilles versus something like running, for example?
So the specific injuries, and I'll get to the kind of specific exercises a little bit later, but to answer that question right now, biking is definitely good in terms of decreasing that shock absorption to the ankle. It's good early on when you don't have a lot of mobility, when the ankle's still really stiff, because you're helping get that range back. Of course, if your sport requires running, requires sprinting or jumping, you still want to get to more sport-specific activities because you want to get back to what you're normally doing. And you don't want to just focus on the things that decrease that load or decrease that shock absorption. That's a good place to start. But as we progress in the rehab, you want to focus on getting back to the specific activities that you've been doing before, or that your goal at the end, your end goal was trying to get to.
Perfect. I hope that helped answer your question. And if not, what we'll do is we'll share Andrew's email after this presentation so you guys can follow up with a few more specific questions, personal questions, if that makes more sense. Thanks, Andrew. That's great.
Yeah, and we'll also have a period at the end where we'll take the time and answer all the questions. So if you want to ask them now, you can feel free. Otherwise, we'll also have time at the end to answer them. Okay, so moving forward. All right, so two main implications to Achilles tendinopathy. So the first one is one we've already talked about a little bit, which is the predisposition to injuries. So when you have Achilles tendinopathy, or really any Achilles pain, that limits your range of motion. You don't want to move your ankle as much because it's creating pain. Now, by limiting that range of motion, you're decreasing the ability for that joint to be as mobile. So it's not able to adapt to different surfaces, adapt to different contacts on the ground, and makes it, in a word, stiffer. But stiff is kind of a really general term, so I'm trying to be more specific in terms of the mobility and being able to react to different changes in surface. Now, obviously, when your ankle is not able to move as well, it becomes a higher risk of injury, not just to the tendon, but to the surrounding muscles, to the joints, to the ligaments, even potential fractures. An example of this, so 75% of total or partial tendon ruptures involved are in activities of repetitive jumping, sprinting, and abrupt loads. A lot of these happen in athletes, and these athletes don't usually have perfectly healthy tendons and then suddenly rupture them. They start by having this inflammatory process, having a little bit of stiffness in the ankle that they may not have been addressing as well, or not seeing a physio for, or not really taking the time to rehab it properly. And by doing this, it's slowly building up that tightness, that limited range, and eventually leading to things like tendon ruptures. The second point is something that actually may not, a lot of people may not think about. It's more of a neural aspect. And I think the participant who said they had chronic pain may actually experience something like this. So when you have something like a chronic tendinopathy, not just in the Achilles, but really in any tendon, people start to show signs of peripheral and central sensitization. What that means is that your nervous system, the nerves that control pain and send pain signals back to your brain, are more sensitive. Now, because you've been in pain for so long, your body is not able to recognize the differences in pain. And even if you get pain in anywhere other than the ankle, the high sensitivity might create a lower tolerance for the pain, meaning that if you try to recover from your Achilles injury or recover from any other pain or other injury, it may start to feel less effective because you're not able to tolerate the rehab as well. You're so sensitive to the pain that it's difficult to really stay consistent with the exercises. So that's another aspect of research that everyone is trying to focus on to see how can we avoid this and how can we decrease the sensitization while also promoting recovery.
Yeah, because that would be a really hard thing to balance, is managing the pain, but still trying to gain strength back. Like that's almost like a teeter-totter type of situation.
Yeah, again, it's all kind of stacked against us. You know, we get pain in one spot, and the more we have pain there, we get pain in other places. And then when we try to recover from the first thing, the pain in other places is stopping us, and it becomes a cycle of inactivity and ineffective rehab. So that's always something that as a physiotherapist and as researchers, we always try to look at and always try to address.
Cool.
Now, I want to talk a little bit about the research. I know not everyone is super interested in reading research and articles, but I'm just trying to pull out the key aspects and really the interesting things that I found in the most modern research. So before we start to talk about the actual research on the exercises, I want to talk about the current struggles that we're facing in researching tendons. So it involves a term called load capacity. So I'm sure that I've explained quite a bit now where, you know, if you increase the load, that's usually bad. And if you decrease the load, it's usually better. But then there's certain circumstances where that's the opposite. It becomes really hard for us to develop proper exercises when we don't know what that sweet spot is, that perfect area of adaptation. So looking at the graph, it's trying to depict that where if you put too much stress on the tendon, you go into maladaptive overstimulation. If you put too little, you become a maladaptive understimulation. Adaptation and homeostasis is that nice sweet spot in the middle, that green area. That's what researchers like to call the load capacity. That's what we're always trying to find, and we're always trying to figure out where that load capacity is for individuals so that we can create proper exercises and proper rehab goals that can help people recover as quickly as possible. Now, it makes it sound kind of easy, but to this point, a lot of research hasn't been able to find that perfect load capacity because everyone's so different. People suffer from different symptoms, and Achilles tendinopathy presents in so many different ways. So we're constantly looking for the ideal exercises or the ones that help the most people in kind of the most effective way and staying within that proper load capacity. Now, a lot of the current research we started in the ankle actually started from research in the knee. It just so happened that really in the past, more people suffered from patellar tendinitis or patellar pain than Achilles pain. So obviously more research was focused towards that. The good thing is the tendon in the patella really acts very similarly to the tendon in the Achilles. So a lot of that research translated really well. So the first study I'm talking about here is actually in the knee, but they use this study as a real basis to really focus on looking more into the ankle. And what this study looked at was what we call isometric exercises. So isometric exercises would be what we think of as sustained holds. So when you're staying in a calf raise and holding up in that position without moving, you're really tensioning that muscle, but not moving and overstretching it. They compared those to what we call isotonic exercises. Those are the more classic repetitive movements. So up and down, push and pull, just doing the movement multiple times and doing repetitions. So the reason they compared those is because at the time, isotonic exercises such as eccentric knee bends, knee straightenings was the gold standard for recovering from patella injuries. Now, when they did the isometric exercises and compared those to the isotonic, what they found was that isometric immediately reduced the pain, and the pain stayed down for at least 45 minutes after the intervention, whereas isotonic exercises didn't decrease the pain as much, and the pain decrease didn't last as long as isometric exercises. So looking at the graph on the left, you can see that isometric exercises after the intervention, the pain stayed down, and isotonic is still gradually went back up and didn't go down nearly as much as isometric. Now, of course, this is a big thing for anyone dealing with tendon pain because it's one of the most important aspects of rehab is being able to reduce pain. Because once the pain goes down, we're able to do a lot more and able to push that tendon and improve our recoveries and recover quicker. Now, the second thing that the study looked at was in terms of muscle strength. This is not as important to just regular day people, but for athletes, and that's kind of what this study was based on, it's really important because being able to increase your strength with your rehab is going to help get you back to sport quicker. What they found was that in isometric exercises, the strength actually increased after doing the rehab versus isotonic where the strength plateaued. The reason for this is something they call motor inhibition. So in our muscles are stimulated by nerves. Those nerves that stimulate muscles are called motor units. When we get injured, our body naturally tries to protect the injured area by inhibiting certain motor units so that you don't turn on as many muscles to create more damage. Now, with isometric exercises, what they found is that it was able to decrease that inhibition of our motor units more than with isotonic, meaning that we now have more muscle activation versus isotonic exercises. Again, this is a very scientific way of saying isometric exercises make you stronger, isotonic exercises keep you the same. And for an athlete that's trying to get back to sport as quickly as possible, even a slight increase in strength is going to sound more appealing than just a regular plateau in strength. So this is another aspect that they tried to carry on when we started looking at this research in the Achilles. Now, when they started this research in the Achilles, they were working along very similar principles as that knee study did in the tendon and really trying to figure out what was the optimal load and optimal criteria that can promote healing. And they found these three things. So the first thing was how heavy did the load have to be? What they found was that when they used little to no load, so just normal body weight calf raises, there was little to no change. They didn't find too much benefit to those type of isometric exercises. However, when they increased the load to a heavier load or 70% of their maximum contraction, they were able to find that it actually had a significant improvement, very similar to the study with the knee injuries. The second aspect was how long that they were under this load for. Like I said, isometrics are sustained holds. So being able to identify how long you sustain the hold for is going to be really important to making a baseline for how we create our exercises and how we create our interventions. What the studies found was that if you hold for a longer duration of at least 45 seconds, there's a significant increase in your ability to decrease pain and increase recovery. Now, they also found that if you sustain the hold for too long, it would eventually plateau and start to decrease. So they found between 45 to 60 seconds is an ideal hold for one repetition. The third factor they found was being exposed to specific loads and putting your joint in specific positions. I'll talk a little bit more about what this means, but essentially, if you think of raising your calf higher, that'll put more pressure and more focus on the tip of the heel versus keeping your calf in a middle point, but focus more on the middle of the Achilles. Because your Achilles is quite long. There's different segments that you might feel the pain in, and not everyone feels the pain in the same area. So what we want to do is we want to focus our range and focus the motion and the joint position on a specific area that we feel the pain in, so we have the best effect. Now, the image on the right was taken from that very same study. And I think it's a really good way to explain the thinking of both therapists and thinking of people who created these exercises on how this benefits people with Achilles pain. So we start at the very top. So we perform the isometric exercises on the ankle. Did the isometric exercises decrease the pain? If yes, then great. We're at a good starting point. We know that it's working. We know that what we're doing is helping. Let's continue with that. Now, if there's no change, let's consider the factors again. Most importantly, is it a heavy enough load? And are we doing it for a long enough time? If the answer to both of those is yes, then maybe we should look at other possibilities and other contributing factors to pain. So examples are peritendinitis in the ankle, or a bursa in the calcaneus, or bursa behind the heel that might be a little bit inflamed, which may present very similarly to the same issues that you might have in an Achilles tendinitis or tendinopathy.
That's interesting. So it may be something completely different, but the symptom is showing up in the Achilles.
Exactly. So not only is this really a good way to improve your recovery, but it's also a good way for us as therapists to determine whether or not there is something else going on. Because if we find that, oh, the pain has changed a little bit, or there's no change at all, maybe we should try to add in a few other things to see if there's any other issues that we may have missed that we can also address and try to work on. Now, the third point, so if we do the isometric exercises on the ankle and we find that the pain gets worse, very similar to what I was just talking about, we may want to think about a different diagnosis. There's a lot of things that might cause pain in the heel that may not be related to the Achilles. For example, patellofemoral pain, pain in the knee can actually refer down to the ankle, because if you have an unstable knee, all that load's got to go down towards the ankle and could be causing that pain. Additionally, so ankle impingement, so the joints and the bones within the ankle could create the impingement that creates pain around the heel and around the Achilles area as well. So these are all just a general flow sheet, a general idea of how we can use our exercises and use our interventions and apply that to our thinking and really try to figure out whether or not what we're doing is effective and how we can change it up. Okay. So the main reason I'm talking a lot about isometric exercises in general is because it's a really great starting point for people who've been dealing with Achilles injuries, dealing with a lot of these, and aren't really sure where to start. You know, there's a lot of information. There's all these YouTube videos and instructional videos on how to deal with Achilles pain. And it gets really muddled up, and it's hard to tell, where do we start? Where is a good starting point that we can focus on first? Isometric exercises are good for that for a bunch of reasons. First of all, your musculoskeletal system, so your muscles, bones, joints, ligaments, they all need to be under some form of load. They don't do well under sedentary or no activity. We want to make sure that we're giving it effective load, effective movement to really encourage and promote recovery as quickly as possible. Secondly, isometric exercises are a lot better tolerated than the other isometric or isotonic exercises. So for a lot of people who've been dealing with Achilles pain, they may be a little bit afraid to move the ankle. It's been so stiff, you know, when they stand up, when they move the ankle, it hurts. So they want to try to protect it as much as possible. The great thing about isometric exercises is you're just doing a sustained hold. You're not having them constantly move the ankle. You're not having them go through really uncomfortable ranges. You're just having them lift the heel up and hold that position. A lot of times when you encourage people that way and you kind of explain the exercises like that, it's a little less intimidating to start the exercises and to initiate rehab with these type of exercises. So it's a good starting point. And obviously third, that's directly related to the research, is that immediate pain relief you feel when doing these exercises really helps with the buy-in and helps you complete your exercises and participate more frequently in the exercises when you know that this is going to help with the pain and it's not going to re-aggravate or make anything worse. So it gets you to be able to return to your activities quicker. So this is very important for athletes who want to get back on the field, get back on the ice, whatever it may be. So they're able to feel more confident and not as focused or fixated on the pain in the ankle. And finally, this is a big one, and a lot of people don't really consider it. It's that exercise doesn't have the same side effects as medications. A lot of people are hesitant to take medications because they know they're going to have side effects. They know that they don't want to rely on it. They don't want to depend on taking medications and kind of build up that tolerance. So exercise is a great way to really encourage them to try to stay away from the medication and just focus on what they're able to do by themselves, and try to motivate them to initiate the rehab and initiate exercise at their own pace and be able to control it a little bit more.
And that's a very cause-based approach, as opposed to just sort of masking the symptoms with a pain relief or muscle relaxant of some kind.
Yeah, exactly. Because a lot of times too, you may not actually have the pain from the Achilles. Like I said before, a lot of areas refer. You could have knee issues that refer down to the Achilles. And if you're just taking medications to reduce the pain, your knee is still going to have problems and your Achilles is still going to have problems as well. And you're just masking the issue. Okay. So now we can start talking about the interventions. This is probably what most of you came here for. So I apologize for making you wait so long to build up the suspense, but this is what you can do at home. So taking all that research, taking all that knowledge and applying it so that you're able to try things at home. Firstly, I want to talk about what a physiotherapist does with this information. So after someone comes in saying they have an Achilles pain, Achilles tendinopathy, or just pain in the heel in that area, there's a couple things we want to look at as physiotherapists. First is we want to look at muscles and tendons. So we try to do some soft tissue release, some manual therapy, because like I said, when you have tightness in the calf muscle, tightness in the ankle, that contributes a ton to the extra stress that's being put into the tendon. So by releasing the tissue, releasing that calf muscle and allowing it to become more mobile and less stiff, we could already be reducing that pain. So that's always a great starting point for us. The second is assessing your foot and shoe orthotics. Now, if you remember the risk factors, they talk about the three that were kind of built, that are kind of together in an encompassing factor. So that's all involved in your foot position. So if we see your foot was like that image before, where it was caved outwards and was putting a lot of stress into the Achilles, we might think, okay, how can we correct this? Should we look into orthotics where we correct your foot position? Do we want to look at possibly different treatments and different ways to correct your foot alignment, or even just looking at if we just changing your shoes might be able to help with that alignment? So that's always something we want to look at as well. For the third point, for biomechanics, this applies a lot to athletes. So if you think of athletes who are constantly running, constantly sprinting, and at very, very high levels, they don't always have the proper mechanics. So if you imagine like a sprinter or a rugby player or someone who does a lot of running, if you watch their mechanics, watch their knees, watch their ankles, sometimes a lot of these athletes, their mechanics aren't great. Their knees buckle in, their ankle turns out, and they're putting a lot of extra load through their tendons that they wouldn't otherwise do if they knew that this was an issue and they corrected it early. So as physiotherapists, we look at their running mechanics, we look at their jumping mechanics, and we look at how their knee and how their ankle moves in response to this. And we say, hey, if your knee's buckling in more, we need to work on controlling that knee stability, strengthening the muscles on one side, increasing the hip range on the other side, just so we can optimize the mechanics and optimize your ability to perform your sport without adding that extra load that you may not even be aware of onto your tendons. And finally is exercise prescription. This is what you can take home and you can continue to work on and build on to really do the majority of the work. As a physiotherapist, we want to make sure that you're equipped with the knowledge and equipped with the information that you can take home and build on to just improve your overall recovery and improve your rehab. So that's what I'm going to get into a little bit after this. So before I talk about the specific exercises, I'll talk about the criteria that we use to determine which exercise is appropriate. First is adjusting the position depending on the portion of pain in the Achilles. This is that third factor that I was talking about in the research. So whether or not the pain is closer to the heel, like in that green circle, or in the middle of the Achilles in the blue circle. So if it's closer to the heel, we might want you to raise a little bit higher, just to put a little extra stress on the insertion of the tendon. So closer to that calcaneus, to that bone. And if we want to focus more on the middle of the Achilles, we might have you not go as high. So you're in the middle range and really focusing on the middle of your Achilles. The second is technique. Obviously, we want to make sure you're doing the technique right. Everybody's body is really, really good at compensating, especially if you have Achilles pain for a long time. Your body knows how to avoid giving you that pain. So what it'll do is it'll create compensation techniques in your knee, in your foot, in your hip. We want to make sure that we avoid those compensations and really target the area we want to be targeting. That'll take a lot of practice. You know, you can use a mirror, just looking at your own alignment, and just generally working on ensuring that you're targeting the right tendon in the right area of your ankle. The third is directly from the research. It's that starting with a light weight and a short duration isn't always the best thing to do. Like I said in the very beginning, your Achilles is the strongest tendon in your body. It takes your entire body weight all the time. It's able to sustain a very, very heavy load. Even if you have this injury, even if you have this pain, don't be afraid to add that excess load to really try to load up that tendon, because it's not going to create extra damage. It's not going to be too much for you, as long as you take it slow and you kind of follow the proper techniques of the exercise. And finally, all the exercises we're doing with the isometrics, with those sustained holds, it's all with the end goal to build you back to function, back to sport. Whether it is trying to return to your job, whether it's trying to return to whatever sport you play, the end goal is always to try to get you back to the functional movements and the movements that you do continuously on a daily basis. So some examples of isometric exercises that you can do at home. The first one is the one that's easily done at home. So single leg isometric holds. Now, the struggle and the challenge with this exercise is that it's hard to get into that heavy load, that so-called 70% of maximal exertion. So a good alternative for this is, instead of focusing on that high load, we focus more on the sustained hold. So you can do a single leg hold and hold it up for, instead of 45 seconds, try to go to 60 seconds or just 65 seconds. Being able to do the sustained hold helps substitute for the fact that you can't necessarily increase the load that you're putting on the ankle as much. The second is also something you can do at home if you have access to weights. So you can do a seated calf raise or a standing calf raise. For a seated calf raise, you can use the image on the right, where you put a weight down on the knee and hold your ankles up, and just use that sustained hold to really feel the tension through the Achilles. For a standing calf raise, same thing. You can use, a lot of gyms may have a calf raise machine to just use and sustain the raising of the heels for between 45 to 60 seconds, depending on how much weight you're able to put through using the weights or using the machine. Next, using weighted calf raises. So if you're in a gym and you have access to the equipment, just using a barbell, using weights overhead, and just holding that weight. You can also do the same thing with a leg press machine. So I'm sure some of you may have used this machine before, others may not have as much experience. It's usually used for quads and for hamstring strength, but using it in the way the image describes here, where you just hold it with one foot and just press it up, that's another good way to do a sustained hold. And it actually takes away the need to work on balance if your balance isn't that great, or if you haven't really achieved the ability to do the weighted calf raise, like the second last image there. Now, this is the return to sport aspect. Once you've done the isometric exercises, once that pain's gone down and you've moved to the next stage of your rehab, where do you go from here? Well, at this point, that's when we start to really add the extra loads, try to get closer and closer to your specific sport, your specific activity. We start with dynamic loading. We get you to start moving around, to put that load continuously through the ankle. So this involves jumping, whether it's drop jumps, reactive jumps, anything depending on how your ankle and how your body is able to tolerate the reaction forces. It can be running, it can be acceleration, so starting and stopping. But a lot of these dynamic exercises to start with are going to be very linear. We're not going to work on too much of cutting, turning yet. We just want to add the load and be able to add a sustained and consistent load to the Achilles tendon. Once you've gotten past that stage, that's when we can get to the sport specific or the activity specific drills. We add in a little bit more challenging aspects. We add the extra tension. So that includes the agility training, where we're cutting, we're turning, we're twisting. We're putting a lot more reactive force and a lot of range of motion and a lot of demands on the ankle that it didn't need before in the previous exercises. We go to more sport specific. So if you're a soccer player, we give you a soccer ball and have you practice dribbling. If you're a lacrosse player, we give you a stick and practice cutting. If you're a hockey player, then we practice skating drills, gliding side to side. So we try to make it as specific as possible to your sport to get you back to that activity. And finally, we involve multiple skills. So a lot of what you're doing, you can just focus on your Achilles, focus on the motion that you're doing. What happens if we add different distractions? Now you have to catch a ball. Now you have to read something while you're reacting or cutting, or now you have to, catch and pass back a ball, or, try to read something or try to focus on something else while you're performing different tasks and also trying to respond to reactive forces in the ankle. So that's always the end goal, and the one we want to work towards is how can we get from your Achilles pain back to being able to perform your sport without the pain or at almost full function.
Now, Andrew, I have a question for you. How do you know when you're ready? Like if we look back at that previous slide, how do we know from the isometric holds when we're ready to go to the dynamic loading? Like, is it when there's no pain at all, or is it a limited pain threshold? Could you explain a bit more about that? There was a great question from one of our audience members.
Sure. So obviously for isometric exercises, the main goal is to decrease pain. Now, the easiest way to determine if you're ready to move on to the next stage is, yeah, for sure, if you have zero pain. However, there's other factors. So the reason why we're doing a lot of these exercises, even while you're in pain, is because we want to avoid the stiffness. So once we get to the point where even if you have a little bit of pain, but your stiffness is improved to the point where the only time you have pain is when you get to the very end of your motion or when you're pushing really hard through the motion, then that's how we know you're ready. So if your ankle is super, super stiff still, and you may not have a lot of pain, I still don't think you would be ready to move into return to sport, because like I said before, if you have a lot of stiffness, you have a lack of joint mobility, you're still at a high risk for injury. So the main thing we're trying to work on is actually how we can get that stiffness to go away. But a lot of times that comes hand in hand with pain. So as the pain is going down, the stiffness will also go down with it. If the pain is going down and the stiffness isn't going down, we might have to try a couple different exercises before we move to the sport specific.
Fair, that makes sense. Now, would you ever consider massage therapy to help with the muscle stiffness, or is this something that needs to be combated in a different way?
Massage therapy is really good. Massage therapy is a really good method to use to reduce stiffness. A lot of times it tackles a lot of the tissue release and a lot of what I was talking about in terms of the physiotherapy intervention. Massage therapy does a lot of similar things, and it tackles a lot of aspects that when you at home are performing these exercises, you're not really able to do as effectively. So it's definitely a good way to complement along with the exercise you're doing at home.
Perfect. Thanks. That's really helpful. I think that really answered this person's question.
Good, I'm glad. All right, so we're almost done. I know I talked about a ton of information. I talked about, research, anatomy, physiology, a ton of really scientific stuff that you may or may not be interested in. Personally, is what I was interested in. That's why I added it in, but I understand it's not for everyone. So if there's really a few key takeaways I want you to take away from this webinar, from this presentation, I just put them in the slide here. So first, isometric exercises can help reduce your pain and also increase your strength. The reason it does that is because it's decreasing the amount of motor units it's inhibiting and allowing for more muscle activation. Whereas eccentric exercises, which would be your isotonic, didn't retain as much pain reduction, and it also actually created more fatigue. So you're getting more tired and not getting as much pain relief from those type of exercises. Therefore, isometric exercises are usually a better starting point versus doing isometric exercise or eccentric exercises, sorry. Secondly, changing the pain receptors locally in the Achilles tendon may help affect the global receptors. That's that central sensitization I was talking about. Decreasing the pain in the Achilles may help decrease the sensitivity of the rest of the pain in your body and other injuries that you might sustain. Third is that aspect of load capacity. So if you think of different ways of increasing, decreasing the loads to the ankle, there's still not a lot of wiggle room and still really hard to find that perfect space for adaptation that we're looking for. And for that reason, we're still doing a lot of research. We're still trying to find the most optimal form of exercise, the most optimal type of exercise for different stages of recovery, and really just continuing to look at how can we better create an adequate load capacity that works for most people or as many people as possible who suffer from Achilles pain or Achilles tendinopathy.
That's awesome. So I have a really good question from one of our participants. It's more around the side of stretching, Andrew. So
Okay.
this gentleman, Russ, he says, is what I call the runner stretch. So leaning against a wall, stretching the leg and forcing the heel to the floor advisable. Will this help with calf release, and will it impact the Achilles? Do you think that's a good one to start with?
It's a good question. So there's two parts of that. So I'll address the first part, which is if this is helping with calf release. It's not as much helping with calf release. However, it does help get you more range of motion. So a lot of that stiffness I'm talking about, it happens most in what we call dorsiflexion. So the ability to bring your ankle upwards. By doing that runner stretch, so leaning towards the wall, you're able to get as much range as possible and slowly build on that range. A lot of times as you're doing that, your calf muscles are still going to be really tight. You want to combine that with a bit of tissue release. So if you have an active massage ball, trying to put that along the calf muscle, helping release the tissue first, then going into that stretch, you're kind of doing a bit of both. So now you're adding the tissue release along with improving the range. So that's kind of the best way to get kind of the active range back, decrease the stiffness, and also improve release.
Okay, so we always want to release the muscle first in a more active way before working on range, regardless of the body part?
Not always, but the pairing the two together is always beneficial because you're targeting your muscle in as many ways as possible. There's not always one cause to your pain, one cause to your issues. So you want to try to tackle as many things as possible, as long as it's tolerable. That's the key aspect. So a lot of times people will still have a lot of calf pain and it may not be as tolerable to do the muscle release. Just doing that range of motion in the beginning is a good way to make sure you don't get too much tightness and too much stiffness, while also understanding that you're going to have a lot of pain still, and you need to make sure that pain goes down as well. Now, for the second part of that question, in terms of how this affects the Achilles, it does have a little effect on the Achilles because you're putting tension on the calves, which in turn puts tension on the Achilles. But it is found that using more active exercises like calf raises, heel drops, put more tension on the tendon because it's also working both the muscle and the tendon. When you're just stretching, the muscle is off and it's just trying to loosen up. So it's not as targeted towards the Achilles tendon.
That's interesting. That's helpful. And I did let Russ know that if he has any more specific questions about his injury or his muscle tightness, that he can contact you via email and you guys can kind of chat more a little bit that way for sure as well.
Perfect. Yeah. So that brings me to the end of my presentation, or the aspects that I was going to talk about. So I said I would leave some questions or some room at the end for questions. So if you have any additional questions that you've been saving up, feel free to ask me now. And like Robin said, you can also contact me through my email, which I'll actually put on the slide now.
Perfect.
So yeah, you can ask your questions now or send me an email as well with your question, and I'm happy to answer it and talk a little bit more if you had any additional questions.
I honestly think that was so helpful, Andrew. I personally have learned a lot, and I know that there was some really great questions asked by the group today. So I think you've answered a lot of those. I have also, for those of you who are interested in more specific one-on-one attention, I have entered Andrew's direct booking link in the chat. And yes, Sandy, we will be sharing the presentation for those of us with short memories. Don't you worry. So we have recorded this presentation. We are going to be sending it to all the registered participants likely tomorrow by the end of the day, along with a copy of the slide deck as well. So if you prefer to re-listen or look at the slides, you can do it either way. And then if there's any questions from there, you can follow up with Andrew directly. And I would really like to mention too, Andrew works in our Markham office Monday through Friday. So he is accessible there. He does offer a wide variety of in-person appointments, but also virtual. So if you're finding it harder to get out and you have just sustained an injury and you'd want to work with Andrew virtually, he can also do that with you that way. And we really appreciate everybody joining tonight. I think there is one more question. And I guess it's more from a how common or what's the most common sport that you see or activity perhaps that you see Achilles tendinopathy coming from?
I would say sport is challenging. It's a mix between a few, but the most common activity is definitely still running.
Okay.
Running, it's because if you think of all the risk factors, it includes so many of them. So if you're wearing the wrong footwear, that can create a problem. If you're running on like outdoors versus indoors, outdoors is really uneven. It's a lot of gravel running. That could create an issue. Even if you're a marathon runner, just running a long distance could create the issue. So a lot of it, I think, comes from running, and it's one that affects a lot of people, not just high level athletes, but just regular people trying to stay fit.
So that's those of us who are like, oh, I should go out for a 5K run today. That'll be a great workout. And then we end up with Achilles pain. We're probably some of the number one culprits of this injury, would you say?
Yeah.
Perfect. Well, I just wanted to thank you again, Andrew. I think you did an incredible job at sharing your information tonight. You're very passionate about this subject, and I think you lined it up really well. So I just wanted to thank you on behalf of everybody at Hansberger, and also thank you to every one of the participants who asked some really great questions and took time out of your evening to join us tonight. I know Andrew would love to hear from you. We would love to learn what you learned most from this webinar and what was one key takeaway. So if you'd love to follow up with Andrew on that, that would be great. And again, Andrew is available in our Markham clinic Monday through Friday, and the booking link is included in the chat. So we hope you have a great evening, and we hope to see you again soon.
Yeah, thank you so much for coming.
Thanks, guys. Nice job, Andrew. If you want to stop the recording now, that would be great.
Mm-hmm.